தெரியலம்மா.
Malati must have been ready, sir, because she prepared in the morning.
No, sir. Jonathan is also ready, sir. He just spoke.
Okay.
Shall I start the presentation, sir?
Jonathan, you please share your PPT, Kana.
Sir, shall I start the presentation without the PPT, sir? The PPT will get ready in 2 minutes, sir.
Okay, you start your presentation. Once your PPT is ready, ask them to share. You have the script with you?
Yes, sir.
Yes. Somebody is helping you?
Yes, sir. Helping me with the slide, sir.
When the sound comes, so you are.
Give me 1 minute. Jonathan, if you are ready with the script, please start.
I am ready, sir.
Yes.
Sir, my case is a 74-year gentleman who is hailing from Kanyakumari, who is a butcher by occupation, who came with complaints of abdomen pain for the past 3 months. And history of personal illness, the patient developed abdomen pain for the past 3 months, which is predominantly in the upper abdomen, more towards the right side, which is insidious in onset, dull aching type, which is not associated with nausea or vomiting. The pain is not radiating. There is no specific aggravating or relieving factors. And there is no history of jaundice, no history of vomiting, no history of fever, and no history of abdomen pain, abdomen distension, and no history of altered bowel habits, no history of trauma, and the history of loss of weight and loss of appetite is there. No history of any chronic drug intake, no history of any breathing difficulty, chest pain or hemoptysis, no history of bone pain, or no history of any recurrent attacks of hypoglycemia. The past history, patient is not a known case of diabetes mellitus, hypertension, COPD, coronary artery disease, or hepatitis patient, and no history of any surgeries in the past. Personal history, patient consumes non-vegetarian diet, and sleep is normal, bowel and bladder habits normal. He's a chronic smoker and alcoholic who stopped 3 months back, and he consumes 3 cigarettes per day and consumes 90 ml per day of alcohol. Family history, he's married and has 2 children. No history of any similar illness in the family. No history of any liver disease or jaundice this running in the family. Summary, 75-year-old gentleman who is a chronic smoker and alcoholic with no comorbidities, presented with complaints of upper abdomen pain for 3 months, which is associated with loss of weight and loss of appetite. Shall I proceed with the examination?
Kana, your pictures, clinical picture slides are ready, Kana? Jonathan?
Sir.
Yeah, then you share the PPT so that the examiners can revisit the slides.
I will.
Yeah, take your time.
I will add.
You have clinical pictures separately, you can share that separately, ma, if you have not put into the PPT. Warmly welcome Professor Ajay sir and Professor Ibrahim sir. Yes. Faculty, you would like to go back to the slides of presentation, or can we ask them to go with the clinical findings, sir?
Ibrahim, go back to the slides of presentation.
Yes,
so we can go with the presentation, but I think the presenter has given ample findings in the history itself. So if he can give a provisional diagnosis with the history, at least the organ where the pathology is, it will be fine. Then we can go with the examination.
Yes, sir. Jonathan, you please sum up your history again.
Sir, by history, that the patient tells only the abdomen pain. That
you say the summary of the history.
The summary is a 74-year gentleman who is a chronic smoker and alcoholic with no comorbidities, who presented with upper abdomen pain for 3 months, which is associated with loss of weight and loss of appetite. That no history of altered bowel habits or no history of. That's it.
So by history,
How,
what are the
how did
possibilities
you
of-
ask the history of hypoglycemia? If I heard correctly, that there is no feature of hypoglycemia. And
Yes,
why
sir,
did you ask that?
Sir, HCC is a hypoglycemia is a paraneoplastic manifestation.
Sir is not asking the reason. Sir is asking how did you ask the question?
Say, history of any fainting episodes, history of lightheadedness.
What are the various features once somebody has a hypoglycemia?
So, history of lightheadedness,
Yes,
history of sweating.
yes. Irritability. Okay,
What will
one
be
of
the
the very
signs?
important feature of the hypoglycemia is the irritability. Okay, there may be
Irritability.
yes, sweating may be there.
Yeah.
Lightheadedness
Sweating,
may be there. So why did you
So, shall I-
think in this patient the paraneoplastic syndrome based only on the history?
Like,
What was there in the history to suggest paraneoplastic syndrome?
in the history, there was nothing much in that.
So you must have thought something, and that is why you asked that question. So what was your impression by history, and why you asked this question?
So, patient didn't complain of the mass of the abdomen, that mass for abdomen. That, but the patient had a like mass, a clinical obvious mass in the right hypochondrium and the epigastric region.
No, Jonathan, what the examiners are asking is, as per the history, the only complaint is abdominal pain. So upper abdominal pain, it can be anything. It can be gastritis, or it can be just colicky pain or urinary colic, anything. So what sir is asking, what made you to proceed with paraneoplastic syndrome questions? So this is not a routine flowchart like thing, but it's a schematic. History taking is an art. So why you chose to take those questions? That's what sir is asking.
You come out with your answer, what you thought and why you asked.
Probably you must have asked this question after you have reached to the diagnosis, isn't it? That is also a style. That is also a style that once you reach to a diagnosis and then you start thinking about that what are the things we have missed in the history. That is also not correct. That is also correct. So probably you must have reached to a diagnosis of something like that, and then you have come back with the asking about the history of hypoglycemia.
Yes, sir.
Is it? Okay.
Wait,
Shall I present my slides, sir? My slides are ready, sir.
Yes, please go ahead. Yeah.
Is there any history of alcoholism in this patient?
Yes, sir.
How much?
3.
Was he
He
regular
consumes one,
drinker or it was occasional drinker?
Occasional drinker, sir.
Mhm. So based only on the history, okay, his history is only the pain in the abdomen, isn't it?
Yes, sir.
Or
Yes, sir.
does he give history of mass in the abdomen also?
He didn't tell about the mass, sir. But on examination, we found that they had the mass.
On history only. On history, does it tell about the mass or not? On history, does it tell about the mass in the abdomen or not?
No, sir.
So only pain is there.
Only pain is there, sir.
To tell what are the causes of pain in the upper abdomen in a 70-year male patient.
uh,
Jonathan, are you trying to share the PPT, ma?
yes, sir.
We have, are you okay with that? Yes. We have Professor Abhay Dalvi sir, Professor Prabhakaran sir,
Is
Professor
the-
Pradeep Sharma sir, many other senior faculty joining for this evening. So, Jonathan, please continue. I think we are able
Is
to
the
see your
slide-
slides.
Is the slide visible, sir?
Slides are visible, Kana, but we are not
Dear-
able to see you on the video. You're okay now? Yes, we are able to see you.
Jonathan, you concentrate on the examination question is asked. You don't in a hurry. Huh?
Are you okay now?
Yes, sir.
Okay, please continue. Good luck.
Yeah, Jonathan, based on the history, 75-year male patient presenting only with the pain in the abdomen, isn't?
Yes, sir.
Yeah.
So,
What is your provisional or
sir, with
your
the
thoughts
history,
about what can be the cause for that?
sir, with the history, I couldn't come to a conclusion there because he complains only of the abdomen pain. And that is the loss of vein.
Once the pain in the upper abdomen is there in a male patient 70 years, at least you can say that there may be gallbladder pathology may be there, or a liver pathology may be there, or a pancreatic pathology may be there. At least you can say that, isn't it?
Yes, sir.
So Jonathan, in short, actually with the history taking, at least we should know the organ of pathology, at least what are the possible organs of pathology, so that we can go ahead with the examination in detail of those particular organs. So as of now, Sarah has told so many organs which may be the cause for the pain. So any other organ you wanted to think of?
No, sir.
Okay. So I think we can go ahead with the examination, sir.
Yeah.
Examination, the patient was examined in a well-lit room after obtaining consent. Patient is conscious, oriented, cooperative, moderate to built and is ill-nourished, and BMI is 16.3. Is the afebrile and hydration is adequate. No pallor, no effects, cyanosis, clubbing, generalized lymphadenopathy or period edema, and his ECOG score is 1, and there is no signs of chronic liver disease. And his vitals is blood pressure is 130/90, and the pulse rate is 84 beats per minute. An examination of the abdomen, inspection, fullness is present in the right hypochondrium, right lumbar, epigastrium, and the umbilical region, and all quadrants moves proportionately with respiration. Umbilicus is normal, position is inverted, no visible gastric or intestinal peristalsis, hernial orifice is free, flanks free, and renal angles are free. On an external genitalia is normal, and on palpation, liver is palpable.
Sorry for interrupting, Jonathan. Jonathan? Jonathan?
Sir?
Yeah.
Sir?
Can you just show me the picture which you showed, a lateral picture? The patient in a lying posture, supine position, but you have taken a lateral picture, lateral view. Yeah. So in that there is some, it's very much visible. So in this, you can see there is something striking. So at the waistline, what you can see, there is a mark. No, what is that horizontal mark?
That is the mark of the cloth is wearing there.
Yeah. So what does it show? There is a reason. Yeah, there is a no. He's wearing it tight, but nobody will wear it chronically. So actually, it is actually a thread, the waist thread he was wearing. So that has become tight. So that means he has recently developed some abdominal wall distension, abdominal wall edema. Got it? And you can see the chest wall, the intercostal spaces are indrawn. So the nutrition is poor. but the nutrition is poor, but abdomen is getting distended. So now you have got some ideas regarding the diagnosis, right?
Yes, sir.
So this can be mentioned. This should be mentioned, in fact, in the inspection aspect.
Okay, sir.
Okay, you can go ahead with the palpation.
On palpation, so the liver is palpable 10 centimeters below the right castle margin, the mid-clavicular line, and occupying the right lumbar, right hypochondrium, right lumbar, umbilical, epigastric region. There is a minimal tenderness is present on palpation, and it moves on respiration there. And on palpation, the surface was nodular and it was firm in consistency with rounded margins, and there was no thrill or rub palpable, and no other masses were palpable, and the bilateral renal angle and flanks were free there. And there was no free fluid on palpation there. In percussion, dull note was heard over the mass, and the dullness was continuous with the liver dullness, and the resonant was resonant to the rest of the abdomen, and the liver span was calculated 20 centimeters in the mid-clavicular line, and there is no shifting dullness. And on auscultation, there is no audible bruit heard, and the normal vowel sound was heard. On digital rectal examination, there was no skin tag, fecal staining was pressed, the tone was normal, no growth was palpable, no supraclavicular fullness was seen, and skull and spine examination was normal. Other system examinations were normal, and summary of my findings is a 74-year-old gentleman with a chronic smoker and alcoholic with no known comorbidities, who present with complaints of dull aching type of upper abdominal pain for 3 months associated with loss of appetite and loss of weight. On examination, the liver mass was palpable 10 centimeters below the castle margin with firm in consistency and rounded margins, and nodular surface with no other mass palpable in the abdomen. It could be a case of liver mass. It could be a primary liver tumor or a secondary liver. There.
So why do you want to come to a diagnosis of malignancy in this patient? What are the points for and points against? And why not some other infection? Patient is a butcher by occupation. He can have an hydatid cyst or something like that, or some other parasitic infection with a parasitic cyst. So what are the points for and against malignancy here?
There is no history of fever there, and patient is afebrile, and there is no history of loss of weight and loss of appetite is there. The age is 75 years, the age, older age.
Jonathan, this mass is mainly in the epigastric region, is it?
Yes,
But it's in the right abdomen. Is this mass mainly in the epigastric?
Mainly in the epigastric region and the right hypochondrium. Also the right hypochondrium.
You are only keeping a possibility of the liver mass here?
Yes, sir. Since liver is extending till the mid-clavicular line.
So what sir is asking is, can it be a carcinoma stomach with liver metastasis? How do you exclude it? Wise or examination wise?
So there is no other history of any altered bowel habits or no melena, no thing there, and there is no visible gastric peristalsis. There is no mass palpable.
If I say it is a case of pseudopancreatic cyst, patient is alcoholic, chronic pancreatitis, pain along with also there is a decrease in appetite.
sir.
and there's a lump which is there mainly occupying the epigastric region. What are your objections to that? There's a patient with pseudopancreatic cyst.
But, so, but the mass is it's palpable throughout the mass, except in the right hypochondrium, umbilical region, and everything. Everything only the mass is there. Then.
That is
There
pseudopancreatic
is a
cyst
place
also
for
you
the
can consider the
pseudopancreatic
mass.
cyst.
What are the points against saying that this is a pseudopancreatic cyst? Concentrate on the questions and answer to that. Don't play with that your laptop.
So the swelling moves with respiration. Then moves with respiration, and the liver motility is continuous with the then.
So whenever such questions of exclusion comes, Jonathan, you go in a systematic way. So first take the points, history points. So there was no history of recurrent pancreatic episodes, no pain referred to the back, like that. So you go in a systematic way so that you won't miss the points. So first take the history. So what are the points against pancreatitis and pancreatic pseudosis? Then go to the examination.
The patient had no history of back pain and no history of the recurrent episode of pancreatitis, and the mass is in the right hypochondrium, which is moving with respiration there, and so.
So there's a mass in the right hypochondrium is there, which is moving in respiration. Why not the gallbladder lump? Why not the gallbladder?
So there is no history of jaundice there. There is no history of jaundice, and
Gallbladder lump, you get the jaundice.
You are,
no.
the sound is coming. Mukesh, probably you can switch off your audio.
In this patient, indirectly, I want to say that you just cannot keep that it is a liver lump, liver mass. You have to think whether it is the stomach mass, whether it is a pancreatic mass is there or not, retroperitoneal mass, gallbladder mass, all these things will be kept in a differential diagnosis in this patient.
Is that?
Okay.
But no.
Yeah. Did you look for the renal angles here?
Yes, sir. I look for the renal angle. The renal angles are 3, sir. No fullness was there and no tenderness was there, sir.
What are the things you look in the renal angle?
So I look for fullness in the renal angle there.
Yes.
And then I will percuss and see whether it is whether there is dullness is there or not there.
So normally the renal angle is dull or resonant?
It's resonant, sir.
It is resonant.
Resonant, sir.
Right. Okay. What is hydrated thrill?
Sir, in case of hydrated disease, while percussion there is because of the hydrated because of the fluid inside the hydrated, there will be fluid till which is going to be seen, can be felt with the percussion there.
How do you
Not
elicit
because
it?
of, it is not because of fluid there. Hydrated thrill is because of the free
What else
daughter
is
cysts
inside?
which are lying there.
Okay.
Okay, free daughter cysts which are lying there. That is why you get the hydrated thrill here. Did you check for the trough space here?
Yes, sir.
What was there in the trough space?
The trough was not obliterated there.
Where is the trough space?
So in the 16th intercostal space there.
In the abdomen or the chest?
Like in the chest side. Chest in the left side.
All right. And what does that signify if it is obliterated?
In case of it can the toxic will obligated in full stomach, and in case of splenomegaly after that.
Okay. So will you like to keep in this patient, if you think it is a hepatic mass is there, apart from, you said it is a hepatocellular carcinoma, what are the other localized masses of the liver?
It could be a hemangioma of liver that, or hepatic adenoma,
Yes.
focal nodal hyperplasia, could be there. And
Any cystic masses, any inflammatory masses?
it again amoebic liver abscess and irid cyst also can be there. Can be a possibility there.
Right.
Can it be a normal anatomical aberration?
Yes, sir. But in case of visceral ptosis or in case of Riddle's lobe hypertrophy, that can be there. But
So Riddle's lobe is in the epigastric region?
no, that
Hmm.
no, in the right hypochondrium. Sir.
Mhm. Okay.
How do you rule out it is not a secondary?
No, sir. In case of secondaries, there will be there can be implications will be there, sir. Not implications, but
It's very, very, very difficult to
but
demonstrate
difficult to
implication.
demonstrate. We couldn't find that.
In your case, you said it is a nodular surface.
It's an nodal, sir. And sir, in case of secondaries, it will be the rounded margins will be there. That rounded margins and
Your case also you said rounded margin. Rounded
Rounded
margin
margin.
is not a big secondary. No, how
And-
confident you are saying that it is only a primary as a first possibility, not a secondary? There must be some reason right from the history or anything. You must start and say that why you are not thinking of a secondary, but thinking primary as a first possibility.
I'm thinking of the primary because there is no other history of such of any GI, no GI disturbances or no that. So
Patient may not have a symptom to you. It have been something happened many, many years ago. It still can come with a liver secondary.
sir.
You had in the history, and I think you said many reasons to say that it is a primary.
So the is an alcoholic, sir. When alcoholic, then
Alcoholic.
cirrhosis which is turning.
Alcoholic, you said there are no other chronic liver disease symptoms.
Yes.
Alcoholic has to cirrhosis has to lead on to the hepatocellular carcinoma. But here the patient has no symptoms of cirrhotic liver, no? Cirrhotics
No,
or
sir.
any liver derangements.
But there is no other signs of chronic liver disease, sir.
So how you are going to proceed?
I will, as a clinical extension, I will go with an ultrasound of the abdomen to note, to look for the organ of origin, to confirm the organ of origin, to find, to see whether about the tumor characteristics, sir, and to look for the IHBR direction for an ultrasound first, sir. And then I will proceed with the MRCP or CT. And I will, to rule out any other masses in the abdomen also, first I will go with the ultrasound.
Will you do any blood investigations before doing CT?
Sir, before ultrasound, sir.
No, before you are planning to do MRCP, no?
I said.
MRCP, CT and all. Before that, you would like to do any basic blood investigations?
I will do a urea creatinine there to look for RFT. We are planning for triple by CT for urea creatinine.
No, you told the organ is liver. Any blood investigations to look for liver?
Yes, sir. I will do a LFT there to look for.
So in all examinations, try to avoid abbreviations. So you tell it as liver function test, not LFT, okay?
Sure.
Yeah, what are the things you would like to see in the liver function test?
So I will look for the bilirubin there. Bilirubin, direct and indirect bilirubin, and then the enzyme there. SGOT, SGPT, and alkaline phosphatase. That's all we will be looking at.
So any other specific enzyme you want to see for an alcoholic?
Gamma glutamyl transferase.
Gamma glutamyl
Transamylase.
Transpeptidase, okay. Gamma GT, transpeptidase, okay. So what do you expect? So what do you expect with the enzymes? So SGOT, SGPT, Gamma GT, ALP, what will be the level in this patient? What do you expect in this patient?
So there will be gamma glutamyl transferase level will be raised there, and there will be reverse that AST will be more than AST in the 2:1 ratio that.
Okay, you are telling about AST, ALT, no? Which is SGOT, which is SGPT?
So AST is SGPT there.
Sure. Basic question, no?
Oh, sir.
You have seen so many things as an undergraduate, at least
Sir,
you can.
ALT is SGPT there.
Yeah, AST is yeah, okay. So go ahead. What about the protein levels? What do you expect in this protein? I also mentioned about one finding. There was one mark in the waist. So what do you expect with the proteins now?
So the albumin globin reversal, sir. I'll look for the total protein and albumin there.
What you are expecting in this case? Because already there is an edema has developed. Whether you get a protein, any change you are expecting?
So the albumin level can be low then.
So what is the normal average albumin level? Can you tell me?
It is 4 that.
So whenever they are asking some average level, always tell a range. There is no absolute number in physiology. Okay. So 4 to 5 grams.
3.5 to 5 that.
Okay. What is that? 3.5 to 5 kilograms per meter square.
Grams
Joules per second. What do you want to say?
Gram per deciliter that.
Gram per deciliter. Okay. So in this case, what will be the albumin level? Sir is asking.
It will be low.
Yeah, low. Why it has to become low? So why it has to become low?
Because there can be the liver is the only source of can produce albumin, so this can there will be liver dysfunction.
Yeah, see, Jonathan, liver is a wonderful organ which has a lot of functions. Okay, it has metabolism function, so it has synthesis function, and it has excretory functions. Okay, so metabolism function only. That's why you are asking about hypoglycemia and all. Okay, because it is with the glucose metabolism, right? And it one of the most important synthesis function is albumin synthesis. So you ask about this synthesis function. Okay, so AG reversal. What is that AG reversal?
So in case of liver dysfunction, there will be AG reversal that.
Okay, so you are telling that liver has enlarged, so the liver volume is more than a normal person, correct?
Yes, sir.
in this patient. So why do you expect the liver function to get lost? Normally, liver has a very good reserve. Even up to 20 to 30% liver is sufficient to have the normal functions. Why it is getting hampered here in this case? The liver volume is more, but why the functions are reversed?
But the liver function need not be like there is extensive liver involvement. There will be liver dysfunction there.
So actually, what is malignancy? Malignancy is overpopulation with inefficient cells. Okay. So even though the liver size, the liver mass is more, the cells are not the normal liver cells. It is ineffective. Like in leukemia, you have more number of WBCs, but still the patient gets infection, right?
Yes,
so normal liver function doesn't happen. So that's why you have all this deterioration or derangement in the liver function test. Okay. So next, so you have done an LFT, you have done urea creatinine and counts, and also you have done an ultrasound abdomen. So ultrasound abdomen just shows a hepatomegaly with a nodular liver surface, and there is minimal free fluid. So what is the next course of action? What is going to be? You are going to do any treatment, or you want to further investigations?
Sir, then the hepatic mass there, sir.
Yeah, ultrasound shows hepatomegaly with a nodular surface and minimal free fluid. No other findings anywhere. So what do you want to do now?
I will go. So I'll do a 555 CCT there, hepatic protocol, and then I will also do a.
You already find out by ultrasound there is a liver mass. Then why do you want to have a CT?
So with CT we can differentiate the primary and secondary. Then
To differentiate?
primary from secondary. Secondaries.
Ultrasound cannot differentiate, and you are saying CT will differentiate. So how do you differentiate?
And then I will on the free fluid I will do an aesthetic mapping.
Priyanka Mitra, please close your audio.
Exercise you get for both the legs. Why do we need for both legs? Both legs are not.
Go ahead, Pav. How do you differentiate primary or secondary?
The primary so there will be the primary there will be early enhancement and arterial phase and early washout there seen there and in secondaries there will be later washout because of the hepatic portal vein, because it's a WA portal vein, there will be later late enhancement of the disease secondary set, or minimal enhancement only will be there seen in secondary set.
So number one thing with CT is you can see other organs.
Other
So
organs
like
also
stomach,
rule
and
of the primary side set.
yeah, those things can be seen. So that is the first thing. Okay. So suppose in this patient, so ultrasound wise it was normal, but in the CT wise you see proximal stomach thickening near the OG junction. OG junction, there are some minimal perigastric nodes, level 1 and 2. So what is your plan now?
So I will do a OGD scope there, upper J scope B.
Yes, go ahead.
And take biopsy from that and confirm that.
You want to see the rest of the bowel or just take
OGD and then a colonoscopy also to rule out synchronous tumors.
No, you do an upper J endoscopy. What I'm
Okay.
asking is, you just reach the OG junction, take a biopsy and come out, or you want to
No, sir, I
see
will
the entire stomach.
enter from the till D2 till the scope goes till D2 I will see.
So why is that important? Why is that important that entering in D2 is important? So you need to
Yes, sir,
know
that-
whether there is any obstruction. Even though history-wise there is no history of gastric outlet obstruction, you
Yes, sir.
wanted to confirm. So if there is gastric outlet obstruction, the
Yes, sir.
first thing, even in case of a metastasis, is palliation of the symptom. You need to do some bypass.
Yes, sir.
But if there is no obstruction, there is no need for surgical intervention. In such a case with a metastasis, you can go directly with a palliative chemotherapy. So that is very important. And if you already see a gastric outlet obstruction or any stomach lesion along with the metastasis, there is no need to do colonoscopy and all. CT wise, there is no colonic lesions. No need to search for synchronous lesions in every part of the body. Okay.
Okay, sir.
So you take a biopsy. The biopsy comes as poorly differentiated adenocarcinoma from the OGD scopy. So no obstruction. Your scope has already entered D2. So what is the line of management?
Sir, so if I go for palliative chemo, then
Do you want to correct anything else before starting palliative chemo?
I'll correct the nutrition status then.
So how you will correct? How you will correct the nutritional status? IV, oral. You want to give albumin? What do you want to do?
Tell albumin will give that.
So what are the indications for giving IV albumin in a case?
The correct
IV
anemia.
albumin.
So less than 2.5 will give albumin.
Okay, so I won't go with the albumin. So you can, patient doesn't have any obstruction. So you go with the normal enteral nutrition, high protein diet, and then start on palliative chemo. Suppose in the CT scan, you see hepatomegaly, nodular surface of liver, and you see a lot of portal collaterals. So what is your line of management?
Portal collateral.
Yeah, portal collaterals. There are some splenic vein communications. So what will be your line of management?
Since the patient is in portal hypertension there, so I will do stenting procedure or I will do shunt surgeries and then proceed with that.
So actually, there is no clinical history wise, no evidence of portal hypertension.
Yes, sir.
Examination, clinical examination wise, no portal hypertension. Only investigation wise, there is some evidence of portal hypertension. So would you like to do a shunt surgery for this patient?
No, sir.
So if there are no symptoms, there is no need to do a shunt surgery.
No, sir. Yes, sir.
So how will you manage that patient?
So I will give. I'll put him on propranolol there to raise the portal pressure.
Okay, so you are treating the complication of portal hypertension.
Yes, sir.
So one of the complications. So what about the primary? What about the liver? There is a liver lesion, no? How you are going to do about with it?
Sir, we'll plan for resection that the mass.
Resection?
It's a resection or a transarterial embolization there.
No. Both treatment are exactly opposite. So what do you actually want to do? So you are telling it as malignancy, right?
Yes, sir.
So when in any case of malignancy, the first step is confirmation of diagnosis. So tissue diagnosis. But there
Yes,
are
sir.
two places where tissue diagnosis need not be done. So what are the two places?
In hepatocellular carcinoma and renal cell carcinoma, sir.
Okay. So here tissue diagnosis is not needed
Yes, sir.
if the lesion is operable. So next thing in any malignancy is metastatic workup.
Yes, sir.
So what metastatic workup have you done here in this patient?
They have done a CT chest, sir. CT chest and but we didn't X-ray of long bones, sir, but we didn't do a bone scan. Bone scan is not available, so we didn't do a bone scan, but X-ray of long
No,
bones.
normally liver primary, where it will go?
Go to
Metastasis.
lungs.
Hepatocellular carcinoma metastasis is to which organ?
Yes.
Yeah, lungs. So what is the basic investigation for lung metastasis?
Chest X-ray, sir.
CT chest, yeah.
Yes, sir.
So bone is unusual. Bone mets is unusual. Okay.
Bone is rare in.
Any other superior investigation than CT chest to look for metastasis in all parts of the body?
PET CT, sir.
Yeah, PET CT. Because liver resection is a major surgery. So when you are contemplating something major, you need to be doubly sure that there are no metastasis anywhere. Okay, even though it has its own demerits and a lot of false negatives. So we have to do a PET CT because in most of the places it is available. Okay. So do you do a liver resection? Any guidelines are there? What are the guidelines to decide whether the patient will need a liver resection or a liver transplant? Which one is going to tell that?
Sir, I'll go for MEL score, sir. And the Milan criteria.
What are the criterias and what are the scores you have to see?
First is Child's book score there. First is that, and the MEL
What
score.
is the child score of your patient? Your patient, have you calculated the child score?
Sir, I didn't calculate the value that.
What do you expect? What do you expect at least? So what are the parameters in child score?
Sir, ascites, bilirubin, I think prothrombin time, then this is albumin, encephalopathy.
So in this case, albumin is a little bit normal, no, a little bit less. Hypoalbuminemia, no icterus is there, minimal
No,
ascites is there. Prothrombin time is also normal because no bleeding episodes. So what do you think? Which category it will come? A, B, C? Which one it will come?
Child book A, sir.
Child book A. So you are contemplating for a liver resection now?
We can go for liver resection, sir.
So when you are going for a liver resection, what is the most important thing you have to see before going for a liver resection?
So the tumor should be less than 5 centimeters, sir, and there will less than 3 nodules, and there should be no extra hepatic disease and no extra nodal invasion. No extra nodal invasion will be there, and there should be no distant mets there.
Okay, is there any tumor marker for this case? You told about hepatocellular carcinoma.
Alpha fetoprotein there.
Okay.
And another is a PIVKA3 there.
What is that?
PIVKA3, protein-induced vitamin K absence.
Okay. So, can it be a intrahepatic cholangiocarcinoma?
It can be there, but but it only producing this much mass, and there is no jaundice of that.
No, intrahepatic cholangiocarcinoma can produce a mass. So how will you differentiate that?
So there will be CA19-9 will be positive in
Not on a tumor, even clinical finding, or with the cholangiocarcinoma, what will you get?
there will be jaundice.
What type of jaundice?
Obstructive jaundice will be present in the early jaundice. Obstructive jaundice.
Can you get hepatocellular carcinoma without alpha fetoprotein rise?
Yes, sir. In case of fibrolaminal variant of HCC, there can be this thing. There won't be AFP elevation there.
So if the AFP is elevated, it is a good prognosis or bad prognosis?
Bad prognosis.
So suppose in this case, okay, so you have seen this tumor markers, all the tumor markers are normal. Okay, this AFP, CA19-9, CA, everything is normal. And you are contemplating for a liver resection. You are doing a liver resection. And final histology comes as metastasis from adenocarcinoma. And all PET-CT, everything is normal only, no uptake anywhere, nothing. But it has come as adenocarcinoma. So what you are going to do now? Adenocarcinoma, margins are negative.
So I have to search for the primary cell. But,
No, you already
searched and
searched.
you couldn't find out. You are not able to find out. Only the clue you have is an adenocarcinoma secondary.
I can do a AHC study then.
Very good. So what do you wanted to get by IHC study?
CK7 and 20 cell.
No. Why do you want to do? I'm not asking what are the IHC studies you are going to do. Why do you want to do an IHC study, immunohistochemistry study? What is the help it is going to give you?
Now you know the type of tissue. The next what you want to know?
The origin of the primary.
Yes. So what are the probable primary site?
Could be stomach or a colorectum there most commonly.
If suppose if it is a female, if it's a female,
any adenocarcinoma, breast and thyroid.
Breast and thyroid.
Always.
So you are doing a IHC study and it comes as a colonic origin.
Okay.
But PET-CT, CECT, triple phase CT, ultrasound, and history wise, no colonic lesions. So what is your next step?
So if colonoscopy not done, I'll go for a colonoscopy there.
Colonoscopy.
All
So what do you
investigations
expect?
are proving that you are not able to localize the site.
So in case of colorectal carcinoma, we can go for metastatic there. So in this case, we already has been detected there.
You've already done the surgery. What you are going to do for the colorectal when you are not knowing anything about that? Adenocarcinoma. What other option you have other than surgery? Any other option you have?
Chemotherapy will give that. RT and chemotherapy. Chemo RT can give that.
One option you have is an empirical chemotherapy you can start.
So, Jonathan, so it is a, what do you call it as? Primary of unknown origin. So it's an adenocarcinoma, primary of unknown origin. So if it comes out as colorectum, it is of better prognosis. As you know, in colorectal cancers, you can even treat as stage 4 disease. So you do a colonoscopy, look for primary. If the primary is seen, you resect the primary. If primary is not seen, you give as Sir told, you have to give a chemotherapy and keep on follow up and see a tumor markers. Kanagavel sir, do we have time for some more questions or shall we go to the next case, sir?
You have another 5 minutes, sir.
Okay.
What
So,
are the investigation which has been done for this patient? What various investigation has been done for this patient?
So we have done such triple phase CT set.
Mhm. And what does that show?
It's sort of a primary hepatocellular carcinoma. That hepatocellular carcinoma. And we have done.
Sir, Kanna sir, you are muted.
What is the size of the hepatocellular carcinoma?
So it is so the size is 5 centimeters, 5 cross 6 centimeters in the right lobe of liver, That the report
In which segment it is there?
segment is 5 and 6, sir.
Okay. So if it is a 5 centimeter tumor in the 5-6 is there, what is your plan? And there are no extrahepatic metastases.
No, sir, metastasis, sir.
Yeah, and there are no metastases in the liver also.
Yes, sir.
That's the solitary lesion is there. So what are the various options available to you?
Sir, so he comes under child's book case, and so I can plan for liver resection. That
Okay.
second case.
What liver resection you are going to do in this patient?
Right hepatectomy, that hemihepatectomy.
So what does that comprise?
Removal of the 5, 6, 7, 8 lobes of the liver. That
Mhm.
50% of the liver.
What are the surgical segments of the liver and what are the anatomical segments of the liver?
So the coinard segments, 8 segments that in right 5, 6, 7, 8 and 4A, 4B and 2, 3 Z in the left.
And anatomically?
And the cardiac lobe.
How the right and the left is divided anatomically and how it is divided the surgically.
But the Cantl's line there.
It divides the
right and left. There.
yes and anatomical
The falciform ligament there.
falciform ligament. Right. Okay. So what are the various ways to carry out the resection? So if you do a right hepatectomy, what are the various ways to carry out that? And what are the various special things you require for doing a liver resection?
We go for Kelly's crisis, finger
Yes.
fracture technique,
Yes.
and harmonic scalpels, harmonic ligation.
So what is the difference between a CUSA and a harmonic scalpel?
CUSA.
Both can be used for that. You know CUSA?
Cavitron
Cavitron aspirator जो है ना. So what is the difference between these two? Both are ultrasonic devices. The difference in the vibration.
Difference there is a difference in the frequency of the.
Yes, frequency. Okay. CUSA vibrated around 25,000, while harmonic vibrates at around 55,000. Okay.
So patient is not willing for surgery. What are the other option you have?
So you go for TACE and TAR. There's
Before you must say it's ablative procedures.
Ablative
Only a
procedure.
surgery. What are the ablative procedures you have?
This is transarterial radio ablation, sir, and transarterial chemoembolization by using doxorubicin into that, and then RFA, that radio frequency ablation, laser ablation, done that.
You know what is Habib sealer? Habib sealer.
No, sir.
Okay, Habib sealer is a radio frequency ablation. Okay. So you put the various probes all around the tumor there. So that is the Habib sealer.
What is the principle of TACE or radio frequency, arterial chemoembolization?
So to focus the agent, that destroying agent, there is a localized focusing the lesion, focusing the treatment there.
How do you make that drug to stay there for some time?
And we can
You
add
put
a lipoidal can be added so that to make the drug stay there.
So what is the complication?
Hemorrhage and anaphylaxis and that
Anaphylaxis is very, very rare. What is blue liver?
blue liver. This with the oxaliplatin there.
So even in there, the artery supply in there, that particular segment can go for necrosis.
Necrosis.
Tear, what you are using?
Sir, using yttrium there.
What is the ideal treatment? Patient is just less than 5 centimeter tumor. You try to say the resection, or you want to say a transplantation?
So most ideal is a transplantation there.
What is MELD score?
Sir, MELD score is contains creatinine, bilirubin, INR that score these 3 parameters.
So will you prefer in this patient a transplantation?
Yes, sir.
So where do you get the donor? This is a patient of what age? 70, no?
Only, sir. We can't get.
There is another guy at the age of 25 with the same finding.
Liver will go to them.
Can I, sir, if you have any more question, we'll.
I think we can.
Okay.
We can close down. Yeah.
Thank you, sir.
Can I, sir, you are there?
I just
Thank you,
want to
Jonathan.
ask something to Jonathan.
Please,
Sir,
welcome.
I'm here, sir.
I've joined this to learn rather than ask questions. But looking at Jonathan, Jonathan, just tell me, did you log in with your mobile?
I log in with my iPad that
Whatever, the device was such that the presentation, I could make out that you were working on that device to get the presentations on, and then somebody asked you a question, go back to the lump, and then you went back to the lump again, fiddling around with that device, whichever you are using. Is it correct?
yes, sir.
It's okay. It's okay. Tell me, what is
Yes.
Operation Lindbergh? Because now you are using technology. I want to know whether you know surgery, where it has gone. What is Operation Lindbergh? If you don't know, you say don't know.
I don't know that.
I'm not going to give any answers. Go back and see.
Video you have not seen?
Somebody is sitting in New York, operating on a patient in
Right.
Strasbourg. A lot of things are there. So if you want to use technology during your presentations, and I'm afraid to say disturbed the watchers, it becomes difficult, including the examiners. I'm quite sure the examiners will agree with me that suddenly things changing doesn't work. The second thing to you is, in your history, you had only positive findings of pain, loss of weight, and loss of appetite. Is it correct?
Yes, sir.
Yeah. Now, somebody asked you a question as to what are the possible diagnoses on basis of your history. Now, pain was in epigastrium. There was loss of weight, loss of appetite. the first things in history that should come to your mind are the organs in the epigastrium. Somebody asked you that question too. You could not answer all the questions. They kept on asking you. Somebody asked you about hydatid. Somebody asked you about pseudopancreatic cyst. Somebody asked you about CA stomach. So these are the organs which are listed in the epigastrium, on which basis the history should have been taken. I was there for the history. Nothing was covered. Unfortunately, for the examination, I only saw the photograph of the patient in the lateral position. After that, I was not there. So I will leave it to you. I am only suggesting to you that once you know where the origin is and two symptoms pointing about malignancy or not able to eat, leading to anemia, these are the organs which should be looked at and proper history should be taken. You don't have to rely on investigations and answer that history doesn't give you a probable diagnosis, including organ of origin, is not acceptable to me as a person who has come from clinical and not believing much in investigations till it corroborates. Go according to that, you will do well in life. Thank you so much.
So the patient was complaining pain in the right hypochondrium. He's not telling pain in the epigastrium. That
Even if it is pain in right hypochondrium, loss of weight, loss of appetite, what are the organs? Gallbladder, common bile duct, hepatic flexure, maybe upper pole of right kidney, even right adrenal. Everything fits in. Did you ask and go into details of the history? I don't think you did. I really don't think you did. You have to work on the symptom, related organ. You were relying on ultrasound to give you the diagnosis. This is the unfortunate part of this era, where you wait for the radiologist to tell you what is the diagnosis, and then possibly in 2 out of 10 cases, you will operate on a patient and the patient will not be symptom free. I'm just trying to tell you that. Thank you so much.
Other faculty, would you like to ask anything, or can we call this case a close, please? Jailal sir?
Yes, sir. Good.
Thank you,
Abhay
Jonathan.
sir has given a right input on that, because when you start presenting, you should not go and muddle with your presentation. It's almost literally it was irritating the examiners. And your attention should be focused to the examiner. When they are asking some question, we could see that many times your mind is not here. You are looking at your presentation, and though it is a short time given, but that is not an acceptable one. And the correlation was not appropriate, as rightly said by the sir.
Thank you, Dr. Jonathan. And we gave you very little time. And in spite of that, you performed up to the mark. But as everybody pointed out, in fact, Professor Abhay has messaged me at the start that you are not concentrating. So please take these points when you are presenting in your exam so that you be 100% focused in one. That's the reason I said only clinical picture also is sufficient. You need not make a PPT, right? Not to worry. Good luck for you. Friends, we have the next presentation by Dr. Malati, again from Government Kanyakumari Medical College. This is a case of a malignant lesion from male carcinoma of the breast, and she also has picked up something very unique in this patient. Let me not disclose that. Let the candidate have the opportunity to present. So, friends, Shilpa ma'am, are you with us? I will ask her. Give me a minute. In the meantime, Dr. Malati, please share your PowerPoint and start your presentation.
I think she is with the same iPod.
Sorry, sir?
I think she's with
no,
the
sir,
same
they are in the
iPod.
same place, sir. They belong to the same college, but
Hopefully,
I'm sure.
I can see the screen.
Yes, sir. Yes, sir. Give me one moment, Malati.
Yes.
You start screening.
Yes.
You make the presentation ready.
Yeah, Malti, don't bother. That is not against you. Go ahead. We will tolerate.
Are you okay, Dr. Malti?
So 1 second, sir. Yes, sir.
You're
Yes, sir.
comfortable? Fix your iPad in a particular point. Just concentrate.
Yes, sir.
Don't hold in your hand. Keep over a book or something so that it
Yes, sir.
becomes stable. And use it at a comfortable
Okay,
thing.
sir.
Don't keep standing or doing that.
Yes, sir.
Focus on it.
Okay, sir.
So, friends, we will expect Dr. Shilpa Rao to join shortly. In the meantime, other faculty can take over. Dr. Malti, please introduce yourself, your unit chief and head of the department, and start your presentation. Good luck to you.
Thank you, sir. Good evening, sir and ma'am. I'm Dr. Malati, final year postgraduate from Kanyakumari Medical College. I thank my chief and head of department, Dr. Jailal sir, and Dr. Kanagvel sir for giving this opportunity to present in PG clinics. I'm going to present a case of double malignancy. Shall I start, sir?
Please, ma'am. Good luck to you. Shilpa, ma'am, welcome, ma'am. Please start.
Yes, sir. My patient is a 70 years old male, coolie by occupation, admitted with complaints of swelling over the left chest wall for the past 1 year. Swelling in the right side of upper part of neck for past 5 months. This is my patient. History of left chest wall for past 1 year, which is insidious in onset, gradually increasing in size, which was not associated with pain or nipple discharge. And history of swelling over the right side of neck for past 5 months, which is insidious in onset, gradually increasing in size, not associated with pain or fever. He had history of voice change for the past 5 months. No history of pain, no history of fever, no history of difficulty in swallowing, no history of difficulty in mouth opening, no history of infraorbital pain, no history of ear pain or ear discharge or tinnitus, no history of nasal block or nasal discharge, no history of loss of weight, no history of loss of appetite, no history of cough or breathlessness, no history of jaundice. Past history, patient is a known case of diabetes mellitus and hypertension for the past 3 years. He is not a known case of tuberculosis, bronchial asthma or epilepsy. No history of previous surgeries in the past. Patient is a known smoker who takes 2 to 3 BDs per day for the past 30 years. He has stopped smoking for the past 3 months. He is a known beetle for the past 40 years. He consumes alcohol occasionally for the past 30 years. Family history, he is married and having one son. No history of malignancies running in his family. To summarize, my patient is a 70 years old male who is known smoker and betel nut chewer, admitted with complaints of painless progressive swelling in the left chest wall for the past 1 year and painless progressive swelling in the right upper part of neck for the past 5 months. From the summary, I would give a diagnosis of probably a lymph node with secondary deposits in the neck and the chest wall swelling to be a carcinoma of left. So,
Can you summarize your positive histories, Dr. Malati?
yes, sir. Patient is a known 70 years male, sir, who is a known smoker and a betel nut chewer for the past 30 years. He complains of swelling over the left chest wall for past 1 year, which is painless and progressive in nature, which is not associated with the nipple discharge, and another swelling over the right upper part of neck for the past 5 months, which is also painless and progressive in nature. Probably a lymph node with probably a secondary node.
It's a pure chest wall swelling, or it is any association with the nipple areola complex?
Sir?
It is a chest wall swelling, or is it associated with the nipple?
Sir, it is beneath the nipple areola complex, the left side.
So the swelling is felt only, it is not seen.
Yes, sir, felt, sir.
Felt only.
Yes, sir.
Okay, it's a painless one.
Painless.
Penis. Okay. So what is your probable organ or diagnosis with the history?
So patient is for old age, sir, 70 years, more in favor of malignant etiology. And patient is having a painless lump over the left chest wall, sir.
Okay.
70 years male gender with the painless lump over the left chest wall, most probably a malignant etiology, most probably a carcinoma of breast.
Okay. You
And-
mentioned about some change in voice.
Yes, sir.
So what does that indicate?
Sir, a patient is a known smoker and betel nut chewer with history of change in voice and swelling in the right upper part of neck for past 5 months, sir. So I would give a diagnosis of secondary neck with a primary probably arising from the glottic or a laryngeal larynx. That might be the reason for the change in voice.
Okay. You want to tell it as a double malignancy with the history itself.
Yes, sir. Because left carcinoma left breast couldn't get into the upper part of neck, sir. The secondaries of the breast carcinoma won't metastasis to the upper part of neck, sir.
Can a breast carcinoma go to liver?
Yes, sir.
Can a breast carcinoma go to brain?
Yes, sir.
So can it go to bone?
Yes, sir.
So why not to a right side upper neck?
Most commonly a supraclavicular node is possible, sir, but this one is rare, so I exclude it.
No, in advanced stages or later stages, you can go. So in the history wise itself, if you tell it as a double malignancy, then it is very obvious that you have got a clue. So always stick to a single diagnosis because double malignancy is very rare. So common thing, common. Okay. So in a clinical examination, for a postgraduate examination, you keep this as a DD as a last, but not as a first one. Okay. So I think you can go ahead. Sir, any questions sir, from your side?
If the lesion is on the same side, the node is also on the left side, then the probability the first diagnosis, but entirely a different swelling with the history of positive history of change of voice, sticking on to the same, the breast is the first possibility producing the change of voice and change of side is not an probable first thing. So that should be also kept in mind, but thinking it as a separate is also here one of the possibility that the candidate can have.
Just one point, can I ask? Dr. Sasmal here. Dr. Malti.
Sir, yes, sir.
Yeah, so why have you thought in your mind that it is a lymph node? Why can't it be any other swelling in the neck, which are common, that is thyroid swelling?
Sir, couldn't get you, sir.
Why can't be the neck swelling or thyroid swelling? Why have you thought that it is on the right side, the opposite side, that it is a lymph node?
Sir, it is lateral swelling, sir, lateral side of neck, the upper part. So I'll put first diagnosis as lymph node and I'll have a DD of thyroid swelling also.
Okay, so breast cancer, can it also just be along with thyroid cancer?
Yes, sir.
So that also differential diagnosis has to be kept in mind. But as you rightly said, as it is a lateral swelling, so a lymph node will be definitely the first option. But what is a lateral aberrant thyroid?
In case of papillary carcinomas, there will be a metastatic lymph node, sir, which will be the presenting feature rather than a thyroid nodule, sir.
Very good, very good. Yes, you proceed.
Thank you, sir. On a general examination, patient is conscious oriented. He has a BMI of 21.4. His ECOG score is
Can I
1.
just interrupt for a second? I can't seem to have the volume very well.
Yes, ma'am.
Hello?
Is it okay now, ma'am?
Hello?
Ma'am?
I can't, for whatever reasons, I don't know, maybe. Yeah. Anyway, you continue, but I can barely hear you. Go on, go on.
Yes, ma'am. Thank you. So ECOG score is 1. is afebrile, no pallor, no tick, no cyanosis, no pedal edema, no generalized lymphadenopathy. His vitals are BP is 130/80 millimeter of mercury, pulse rate is 82 per minute, saturation is 97% in room air. On examination of the chest, on inspection, there is a chest wall asymmetry. Left nipple areola complex is higher up when compared to that of right. There is a focal fullness present above the left nipple areola complex. Inspection of the left breast, there is a circumferential nipple retraction present on the left side, and there were whitish scales present over the areola skin. No, there was no nipple discharge. Palpation of the left breast, a lump of size 6x4 centimeters present behind and around the nipple areola complex, which is spherical in shape and consistency. It has irregular margin contracting the pectoralis major muscle. The skin over the lump is not pinchable. Circumferential nipple retraction present. There were no nipple discharge. Examination of the opposite breast, there were no lump palpable. Examination of the bilateral axilla were normal. Examination of the neck, on inspection, a swelling of size 8x6 centimeter present in the right upper aspect of neck at the level 2. The platysmal sign was seen. Skin over the swelling is normal. There were no scar or sinuses. Trachea appears to be in midline. On palpation, a spherical swelling of size 8x6 centimeters, which is hard in consistency, had an irregular surface with restricted mobility and fixed to platysma present at the level 2. There was no warmth or non-tender. No sign of earlobe lifting was present. No other lymph nodes palpable in the neck. The post-cricoid crepitations was present. Examination of the oral cavity. The mouth opening was adequate. The oral hygiene was poor. Nicotine staining of the teeth was present. Malalignment of teeth was present. And there were missing teeth in the lower jaw. There was a leukoplakic patch of size 2.5x2 centimeter present posterior to the right tonsillar fossa with the surrounding erythema. Other system examination of spine, skull, and scrotum was normal. CVS, RS, and parabdomen was normal. On parrectal examination, sphincter toe normal and normal fecal staining was present. No mass palpable. So, on summarizing, 70 years male with swelling of left chest wall for the past 1 year. On examination, it was a hard lump with irregular margins. So I'll give a diagnosis of carcinoma left breast, that is T3N0M0. On examination of the neck, there was a hard swelling of size 8x6 centimeters in the right upper half of neck at the level 2. So I'll go with the diagnosis of neck secondaries with unknown primaries.
Any differential diagnosis for this patient?
Could be a tubercular lymphadenopathy with the tubercular abscess over the left chest wall, sir. But the consistency was odd, and so I'll go for carcinoma.
So, breast carcinoma, clinically it is malignant, but neck, we don't know. It can be anything. It can be an inflammatory, or it can be a malignant, or anything, whatever it is. So, can you just repeat the axillary examination alone?
Axilla, sir.
Yeah.
On examination of the bilateral axilla, there were no lymphadenopathy, sir.
No lymph nodes.
No, sir.
No lymph nodes. Okay. And there was mention about platysma fixity. How did you check that? Platysma fixity?
Sir, there was on inspection, there was a platysmal sign, sir. The platysma stretched. And I asked the patient to open his jaw against the resistance. And there was a restricted mobility. The swelling is fixed to platysma.
No. When you open the jaw, what happens to the platysma actually? Platysma helps in jaw opening. Is platysma is a muscle of mastication or it
No.
help in?
No,
I
sir.
didn't get you. So platysma is a part of what? What is a?
Either-
Which arch? Which
This
arch
is a-
muscle? First arch, second arch? It's a facial muscle,
Yes, sir.
part of a subcutaneous muscle, right?
Yes, sir.
Like orbicularis oculi, orbicularis oris, okay,
Yes, sir.
supplied by facial nerve. So that will not be disturbed by this thing. So that is called retching. Retching of the neck can stretch the platysma or contract the platysma. So how do you exclude a thyroid swelling? Can be a thyroid, no? A lymph node from thyroid. You have not mentioned about thyroid. How is the thyroid?
Thyroid gland was not palpable, sir. There was no enlargement of thyroid gland, sir.
Okay. And you mentioned about some cricoid.
Yes.
What is that? Post cricoid?
Normally, there will be a crepitation while palpating the cricoid, sir. It will be absent, known as the Bocas sign, in case of laryngeal carcinomas.
It will be absent. So actually, have you ever done that
Yes, sir.
on yourself?
Yes, sir.
It will be very painful. Okay, it will be very painful. So it's almost like rubbing the sternum. It is very painful. Normally, we don't do that. So, but it's a sign. It's an established sign. Okay. So, any other questions, sir? An examination.
Okay. I kind of missed a lot of it in the beginning, and my mic was, I think, on unmute. So I think you must have heard a lot of chaos at my end of this thing. But what's your name? You're Dr. Jonathan?
Sir, I'm Dr. Malati.
Malti, yeah. So Malti, how common is it to actually have these two malignancies together? And like, is it likely that one has metastasized to the other, or are they just de novo two different malignancies?
Most probably two different malignancies, no?
Do you know any kind of breast cancers which can metastasize to the oral cavity? Any specific types, or vice versa?
Sorry, no, don't know.
It's very, very rare, but you can have adenocarcinomas which happen in the breast, which can metastasize into the oral cavity, which can present with a primary. It's rare, they're only case series, but it does happen. So it's not absolutely impossible. Yeah. Now, I'm sorry, I missed the thing. So the oral lesion, can you stage it for me, please?
Yes, ma'am.
Okay. So it's just a leukoplakic patch.
Yes, ma'am.
So strangely, the one case report which has been written on this has mentioned a breast adenocarcinoma which metastasizes to the retromolar area of the trigone of the mouth. Yeah, so you should be aware that that is a rare possibility. Other than that, let's just take with both of them separately. Dr. Ibrahim, I think
Please that the
there's somebody else also who needs to be on mute.
BLD1, please. Your audio, please close. BLD1.
Okay. So that being anecdotal, let's just take each of them separately. Are there any common factors for both together? Risk factors?
Age of the patient is old age.
Okay.
And male gender.
Male gender is common for both?
Yes, ma'am.
What is the percentage of breast cancers in male?
No, ma'am, a lump which is hard in when present.
What is the percentage of breast cancer in the male population compared to, like if you have 100 women having breast cancer, what is the percentage of it?
5%.
That's very, very high.
How many cases of male breast have you seen, Malati?
This is the first case.
Yeah. How many carcinoma breast you would have seen in 3 years? At least
So it-
100.
Yes.
So 1 in 100.
Yeah, so it's 0.8%. In fact, is the number of is the percentage. So it's a very rare occurrence in males compared to the female population. Which kind of cancers happen in males?
A ductal carcinoma.
Okay, can you tell us a little bit about what is its characteristic? How?
The
What-
lobular development. Yes, ma'am.
Sorry?
Lobular development is present in the women only, ma'am. So male breast carcinoma is always a ductal carcinoma.
Okay. What are the predisposing risk factors?
Male breast carcinoma is most commonly associated with Klinefelter syndrome.
What is that?
It's a testicular agenesis.
So have you checked this patient?
Yes,
Have you
ma'am.
checked his
Scrotum was normal, ma'am, with the preserved testicular sensation. He's married with one son, having one son.
Okay. What are the other risk factors that can happen?
Association with the BRCA might be there, ma'am. BRCA2.
Which type of BRCA in males?
BRCA2, ma'am.
2. Okay. What else? What benign conditions of the breast may coexist or may aid?
Gynecomastia, ma'am.
Yeah. And anything that causes an increased estrogen level, whatever. So all these could cause for a male breast cancer to kind of appear. What kind of, you said IDC, but what is the IDC of the breast cancer in males?
ERPR positive, triple positive.
Triple positive.
Sorry, ERPR positive.
Which is more positive? So ER is commonly positive, like in females, 80% of them will show ER positivity, 10% less for PR. And what are the other genes which are kind of seen? Overexpression of which genes? Have you heard of the P53?
Yes, ma'am.
Yeah, in addition to the
It's a tumor suppressor.
BRCA2. Yeah, so that can also be kind of implicated, right? Okay, let's go into your management. I think I interrupted you all in the middle of nowhere. So come back to your breast and
So Dr. Malati, you are showing the clinical picture of the chest wall. Can you post it again?
Yes, ma'am.
Before that. Yeah. So what is very prominent here? Something striking?
actually, could we also go back to the previous picture for a second?
Yes, ma'am.
Okay. Yeah, in fact, I feel this one is more representative, but go back, you answer his question and we'll come back here.
Yeah. So what is something striking is the location of the nipple. So the inter nipple distance.
Yes,
What is your opinion about that? Is it normal, increased, decreased?
increased, sir.
It is increased. It is not normal. So it is not in the midclavicular line, right? Can you appreciate it?
Yes, sir.
So any conditions associated with wide spaced nipple?
Barrel shaped chest.
In a female, wide spaced nipple. Which syndrome? Which can turn a female into a male.
Turner's.
Yeah, Turner's syndrome. Yeah. So that's a wide space nipple, but he is a male. So, but there is a striking feature. The distance is increased. Can you can appreciate it, right?
Yes, sir.
Yeah. So next, in the next picture, I think ma'am wanted to ask some questions.
Yeah,
Yes.
can you see something about, sorry, about the nipple?
Yes, ma'am. It is a site of core needle biopsy taken site, ma'am. It's not a satellite nodule, ma'am. It is a site where core needle biopsy was taken, ma'am.
Okay, you're very sure of that.
Yes, ma'am.
Okay, all right. So
Suppose you have an hyperpigmented lesion in that same spot. What are the possibilities?
Could be a satellite nodule, sir. Or
Anything else?
Any other thing other than carcinoma? Anything you can think?
melanoma, sir.
No, you are always interested in double malignancies, I think now.
triple malignancies.
Triple. Yes. So you have a nipple, something next to it, what it can be?
Accessory nipple, sir.
Accessory nipple. So you can see the accessory nipple in what line?
Milk line, ma'am, sir.
Milk line. So
Extending
this lesion can be an accessory nipple if it is not a core biopsy mark, right?
Okay. What else has happened to the nipple?
There is a circumferential retraction, ma'am. And there were scaly lesions around the nipple, ma'am.
Yeah, but is the nipple raised on one side? Because from, I don't know, from this angle, I feel from 7 o'clock to 9 o'clock, the nipple seems to have gone inside, and there is kind of a protrusion of the nipple from 9 o'clock to 5 o'clock from where I'm facing.
Yes, ma'am.
The shape of the nipple, is it normal?
No, ma'am. It's little
But
distorted.
nipple, the areola rather than the nipple, is it normal?
No, ma'am. There is a distortion, maybe due to the underlying swelling lump present, ma'am.
Okay. What is the percentage, which is the commonest area for CA breast in women
Upper outer quadrant.
and in males?
Upper outer.
No, there is
No,
no
why-
upper outer quadrant.
Why it is in upper outer quadrant in females?
More of a glandular tissue present in the upper outer.
So males that don't have that, right? Common sense. Where is it most in males?
Central.
Central, no? Below the nipple areola complex, right? So that's where it happens the most. 50% of malignancies will happen in the central portion of the chest in males. Okay. Okay. What else? What else on your findings? Both the axilla are normal.
Yes, ma'am. No lymphadenopathy.
It's a 4 by 6 centimeter lump. It's a 6 centimeter lump.
Yes, ma'am.
I can't really appreciate a lump that's 6 centimeters on this picture at least.
And suppose if it is a 6 into 4 centimeter lump in a male breast, definitely I would expect an axillary node.
Yeah. It seems little difficult to believe that there is no axillary node for if you're saying the lump is 6 centimeters in its largest diameter. What is
Yeah,
the
that's why
largest diameter, vertical or horizontal?
Vertically 6, no? Horizontally 4.
Okay. And you said mobility is restricted on the contracting pectoralis muscle. I mean, does that really tell us whether it's mobile or not?
No, ma'am, it doesn't imply the chest wall fixity, ma'am. But the restriction is, there were a restriction of mobility while contracting the pectoralis.
So how will it help you in your clinical management of the patient? Does it help?
No, ma'am.
Does it change the staging? Does it
No.
change your, it doesn't, right? So don't write things which are not, which will get you into trouble, right? All you can say is it's not fixed to the chest wall. If it is, or it is not, that you've not written. That is more important, isn't it? Than finding out if the lump is, it's very likely to be fixed to the pectoralis in males. There is not really much else to go on. So write clinically relevant data on your slides. So how would you stage it? Okay, we give you the belief that there is no axilla. What is the stage now then of this disease?
As there is no chest wall fixity or skin involvement, ma'am, I will go for T3, ma'am. And there were no nodes, N0. And there were no symptoms of metastasis, so M0. And T3, N0, M0, ma'am.
You're telling me there is no skin involvement? You can pinch the skin, the NAC away from the mass?
Couldn't pinch the skin, ma'am, but there were no ulceration or satellite nodule.
You have to have ulceration and satellite nodules to have a T4B?
Yes, ma'am, or PUD orange.
So just the skin not being able to be mobile and not being able to pinch the skin over the thing, and the skin being part of the lump is not an evidence of fixity to the skin.
Yes, ma'am.
Malati, the first line and the second line in this slide is contradictory.
Vertically oval.
No, not that. So you mentioned it as spherical in shape,
Yes, sir.
and I would expect a 6 into 6 centimeter or a 4 into 4 centimeter.
Vertically oval. Sorry.
No,
Oval in.
I think you didn't get it.
Oval
Spherical
in
means
shape is not
the
existing.
both axes, it will be equal.
Yes,
So
sir.
it is very, very improbable to get a spherical shape. Malignancies doesn't go into spherical shape. You can mention it as oval, ovoid, or something like that, or irregular. So
So
if
the
it is
best
spherical, means
way-
both axes should be equal.
The best way to get out of that trouble is to tell us the largest diameter. It doesn't matter what other diameters exist. We are bothered about the largest diameter. So what you need to tell us is it's an irregular swelling, the largest diameter of which is 6 centimeters.
Yes, ma'am.
But on this clinical picture, okay, so what is your staging on this clinical picture?
Stage 2B.
I don't agree with you on this. Let's have the take on the other examiners.
So you are giving a clinical diagnosis as CT3 and 0M0, right?
Yes, ma'am.
She's saying it's T2 and 0.
T3 and 0.
3 and 0.
Acha, you said T3. Okay, T3 and 0. Okay.
Shilpa ma'am has to clarify whether this scaly lesion which they are seeing on the areola, can we make it as a skin involvement, or it should be not considered as a skin involvement?
So I can see scaling in the axilla. I can see crusting in the NAC area, and a core biopsy by itself should not give that blackish discoloration over there. I mean, you should see a scar, but it's not very clear. So I would still want to put this as a T4B and rule it out further, because it looks like the whole thing is kind of involved as one mass. You don't have to have a PUDR. I mean, those are all overt signs, but if the skin is stuck there and there's very obvious crusting and scaling in the nipple areola complex in a non-Paget disease, I would still put this as a T4B.
Good.
Yeah, Malti?
Yes, ma'am. T4B and 0M0.
Because again, in male patients, now to have a lump that size without it involving the skin is again a rarity. Okay. So if you can't pull the skin out, if the whole thing, the skin moves along with the lump. Okay, now we are not going to, split hairs and say, is the Cooper's involved or is it whatever involved? But there is definite areas of lesions in the nipple areola contrast. So I would clinically put it as T4B. Then I would go and do other investigations to confirm or otherwise. Okay. Which brings us to the next things that you would like to do.
Yes, ma'am.
Manage this patient. I'll come on screen, I think, so that you can see me for a bit. Yeah.
I'll confirm my diagnosis, ma'am,
Yes, how will you confirm your diagnosis?
by triple assessment, ma'am. I'll go for a imaging, ma'am.
Don't ask me questions. You tell me what you're going to do.
So I'll go for ultrasound of breast with the bilateral axilla, ma'am. And I'll go for a core needle biopsy of the lump, ma'am.
Okay.
I'll confirm the diagnosis through the tissue biopsy, ma'am. And proceed with the metastatic work.
What? No, we'll just go. What all would you see on an ultrasound of that area? What all would you like to look for?
I'll look for the characteristics of the lump, ma'am, whether it is malignant or benign, and I'll look for
So what are the characteristics? Do you know the criteria, the ultrasound criteria for malignancy?
when the lump is taller than wider, it is more in favor of malignancy, ma'am. And if it has calcifications,
Is calcifications really seen so appreciated on an ultrasound so much? Microcals and things like this are seen on a radiographic plate. What else can you see on an ultrasound, which would suggest that it is, you know, there are grades that you have on ultrasound as well, right?
yes, ma'am. Birat's grading. Whether a lump is solid or cystic, ma'am.
Yes. The texture of the lump, the size of the lump, the height versus the horizontal ratio, the vascularity inside of the lump, right? And then any edema, fixity, or any attachment to the overlying skin and the chest wall. All of that you may see. Now you can't do a mammogram on a male in this breast because anyways you would not see anything. So what next would help you understand that there is chest wall involvement? Or any other involvement?
We'll go for
You
a
want to stage the disease.
contrast enhanced CT, ma'am, of chest and abdomen and pelvis.
That will tell you about muscle involvement.
When
Just
you want to study the tissue, what is the investigation you will do?
MRI.
Okay. What else? Is there anything that can tell you a basic, like give you an overall picture of what's going right or wrong in him? You said it is a local disease right now, right? But you still have to stage it. So anything else you would like to do? Something that will, that's a pan investigation.
What is the next level? When you start with the entire body,
PET
Ma'am has
CT.
given all the clues.
all the clue, the first word also she has said.
Yeah, everything is there.
She has started asking me questions, therefore. Yeah. So
Starts
what's
with
the
P.
next
Pan.
investigation, which will kind of tell you a lot of things all in one go.
PET CT scan.
Okay. What is the one investigation you need to do before you send this gentleman for a PET CT? Otherwise, they send the patient back saying we can't do it. It's a very routine investigation, but if you don't do it, you can be in trouble. Does he have any? Huh? Does he have any comorbidities?
What is the dye you use? What is the
Diabetes.
dye you use? Yeah.
You'd like to do a blood sugar, right? If the blood sugar is high, you can't do an FDG uptake,
Yes.
right? Okay, so what all will a PET show you?
We'll show the hotspots, ma'am, the areas of malignant cells due to increased uptake, ma'am. And the metastasis.
Is PET good for local disease staging?
No, ma'am. For metastasis.
So it is good for which kind of metastasis?
Metastasis to which side? It will be
Which
very-
organs? Which organ metastasis?
well picked up.
Where all does the breast metastasize?
Bone to the vertebra, lumbar vertebra,
To the vertebrae.
liver.
Okay.
to liver, lung.
Hmm.
Can
And
go
if the patient is HER2 positive, which is a likely site of metastasis?
From lung, anything above or
Anything that
Malati, you
goes
have to keep talking.
brain
brain and
and ovarian metastasis in case of Crook and Brooke.
and also the choroid plexus. Okay, so all those things can be picked up on a PET scan, but PET is not a good evaluator of local disease. Okay, so in a male, if you're really worried about the chest wall being involved, you should do an MRI.
Yes,
Okay, that is only time it's indicated in a breast in male, and of course in women they had different indications, but to actually stage the disease, it will be difficult if you don't have that as a tool, right?
Yes.
Okay. So this late gentleman is T4B N0, okay, MO N0. Now how will you manage?
As this
TrueCut is ERPR positive, HER2 negative.
you answer quickly, Amma. Why? What's the problem? T4.
Which department you are in?
so, as this patient is another having another malignancy, I'll subject him to
Leave that. Let's just come to this first, and then I will also leave this place, and then you can go into oral as much as you want.
Yes, ma'am. This comes under stage 3B, ma'am, a locally advanced carcinoma. I'll put him under neoadjuvant chemotherapy, followed by MRM.
What neoadjuvant?
Adriamycin and cyclophosphamide.
Adriamycin, cyclophosphamide.
Yes, ma'am.
That's it.
Paclitaxel.
So all together?
No, ma'am. First 4 cycles of adriamycin and cyclophosphamide, followed by taxane.
At what intervals?
4 weeks.
3 weekly, and then Pacli or Dosi. Pacli is given every weekly for 12 cycles. Okay, then you do a MRM on this gentleman. You think that will kind of take care of his disease locally? Most likely the pectoralis is involved, right? If not the chest wall. So surgically you may have to get clearance, right?
Yes, ma'am.
So what will you do? So what are the extended radical mastectomies that you heard of? What all can you take out extended other than a modified radical?
Can remove pectoralis major.
Okay.
Can remove pectoralis minor in order to clear the level 3 nodes.
Major, minor. Okay.
Major.
If you say so. What else? Okay. Now, if you're going to take out all these structures, will you remove the chest wall as well if it's involved?
No.
You will not touch the chest wall.
You can. But the rib is also involved. Chest wall is involved.
Yes or no? There are only 2 options, no, that you have.
No.
Yes or no? No? Okay. So there is a school of thought which says that you can go all the way down to the pleura. I mean, thankfully, it is in the last century. Nowadays, people don't do such majorly radical surgical interventions. They prefer to do neoadjuvant chemotherapy. Is there any other neoadjuvant you can give?
Neoadjuvant Artim.
One is chemotherapy that you give the breast malignancies. What are the other two types?
Radiotherapy. Hormones. Radiotherapy.
Drugs.
Hormonal.
Hormonal therapy and targeted therapy and immunotherapy, right? So there could be a role for immunotherapy pre-operatively in a gentleman who's presenting with something like this as well. And if he was HER2 positive, then yes, targeted therapy, right? Okay, so you would operate after you finish the entire NACT. What is the role of NACT? What do you want to achieve with an NACT?
Downstaging the tumor.
Okay, one is downstaging.
To for the micrometastasis. Systemic.
Okay. Why do you want to downstage this tumor?
To make it operable.
Okay. Anything else you'd like to achieve, which every 2 years correlates with survival, and then again they say it doesn't, but it does, and then they keep yo-yoing between the two things. So there is something we'd like to achieve when we are giving chemo. I think this should be my last question. You want to achieve pathological remission, PCR?
Yes, ma'am.
Have you heard of the term?
Yes, ma'am.
It's very, very important. So 2021, it was important. 2022, it became non-important. Now 2023, again, they're saying it's important. But PCR is a good option to have. It tells you about the response of the patient to the chemotherapy and generally how the patient will do, even if it doesn't translate into overall survival.
Yes.
Okay, so you should know that. And then after that, complete the thing for me, and then you finish surgery, you finish chemo, then
I'll follow up the patient. We'll check the biopsy report.
how and what would you like to do in addition? I said no ER/PR positive.
So hormonal therapy.
What?
We'll put him on aromatase inhibitors.
Are bapre, no, Rani. You do not put them on aromatase. Does he have an ovary?
No.
Tamoxifen.
Yes, ma'am.
Okay, and radiation.
Yes, ma'am.
I'm done, Dr. Kanagavel. I think I should allow everybody else to talk now. I've done my job.
Definitely. Thanks for accepting our late request. But I think you have focused on the breast cancer. Now, I would like to ask the faculty, because definitely this is not a case for postgraduate examination when they have dual or triple lesions. So considering on that, maybe I will request the faculty to discuss or give your viewpoints how this case have to be handled, because it looks possibly a dual or it can be a third one also, the way things are going. And what will be in your take, ma'am? Because she is having a lesion, patient is having a lesion in the breast, he has a node. So with that background, what do you think should be the approach, ma'am?
No, so the biopsy needs to be proven. So the only time when you can have this kind of an extension is if there's an adenocarcinoma. So
Yes.
we need to have I need to know the biopsy report and rule out an adenocarcinoma before I call this two separate primaries. And if they're two separate primaries, unfortunately, then I think breast tends to spread far more faster compared to the squamous, and both would be amenable to radiation eventually. So, I mean, you can obviously do a pan endoscopy and find out, whether there's anything in the pharynx, larynx, or wherever else. But if it's an unknown primary, in spite of investigations, I would approach the breast first, and then I would give the chemo and radiation in a manner that is encompassing both the areas. So maybe a platinum-based chemotherapy, or of course, when we talk to the medoncs and discuss that.
Considering, as you rightly categorized the approach, if it turns out to be a dual pathology, then obviously you have a squamous and this whatever type of breast subtype comes in. As you one way you pointed out the drug choice, which will be able to cover both. But then, are we left with surgery as an option here at all, ma'am? Number one, if yes, what type of surgery will be ideal? Assuming the pathology looks localized, like dual malignancy on one on the neck and one on this side. What will be your take, ma'am? This surgery is going to be a solution at all?
No, if it is metastatic, like I said, if it's an adenocarcinoma of the breast, it straight away becomes a metastatic breast cancer. And then obviously surgery is not warranted unless, it ulcerates and it has skin complications.
Local control.
Where, just to locally control.
Yes,
but other than that, if it's not, if they're two different entities, like this is an infiltrating duct and that is squamous cell, then I would consider a surgical option on the breast as well. And maybe we could do it. I mean, I don't know. Some surgeons could probably do it all together, like to do a radical neck and do all of it together. But yeah, that could happen as well.
Ma'am,
I don't know. Please ask the rest. I would also like to know how other.
Yes, ma'am. I'm going to pull up the other. Professor Khanna, sir. Ibrahim, sir, I think had a telephone call. Ibrahim, sir.
Yes, sir. So,
sir, what is your take on this?
In an exam point of view, we will never get such case, number one. So, ma'am has discussed most of the things.
Yes, sir.
So if it is if all the clinical findings points out to a dual malignancy, so what we'll do is surgery is going to be a short duration treatment. So the ideal thing is the short duration treatment has to be given first. So we'll do if everything points out to be an operable breast lesion, so you do ectomy along with the excision of the pectoralis major. And the next thing is, if the laryngeal lesion or the cricopharyngeal lesion is a T3, most probably a T3 lesion, so you'll go for a chemoradiation. So there is an overlapping chemotherapy which can cover both is paclitaxel and carboplatin. So it can take care of squamous cell as well as breast lesion. So that can be given. So both the lesions will need radiation also. So radiation. So first thing in the neck, it is like concomitant or concurrent chemoradiation. But in breast, it is a sequential. So the sequence of treatment will be like first surgery, MRM for the breast. Next is the chemoradiation for the neck lesion. Then we can give a chemotherapy which covers both the neck as well as the breast, followed by the chest irradiation, then followed by hormonal treatment. So this will be the sequence.
The right cervical lymph node, so the malignancy is on the left breast, right?
Yes, ma'am.
Yeah, and so this is the right cervical. So it's most likely going to be two different pathologies. I mean, it's rarely that the breast is going to go onto the right cervical without having no lymph node in the axilla, which again, I have my own kind of thing on. But normally you don't have such skip lesions happening in breast. Okay, breast pretty much follows a pattern of lesions. So if you're telling me there is a N0 on this side, then that cervical lymph node has to be a separate malignancy. Yeah.
Professor Abhay, sir.
Yes, Abhay, good evening.
Yeah, good evening, Shilpa.
And yeah,
Not
sorry,
meeting
yeah,
you.
I didn't realize my mic was on. Yeah.
No, that's fine. One thing I said, this is a very interesting case. Which one to treat first comes.
You would treat the adrenal first.
The issue is, I think this is the time where in multiple hospitals that I work in right now, have a multidisciplinary discussions that take place between the different departments, and then with the family, all departments involved, and tell them that this is the problem, and according to us, this is the major problem. So let's get cured of this plus, but you got to go ahead with further treatment later. I don't want to get into which one has to get into first, but this is the thing that we follow at Global Hospital as well as Jupiter Hospital. And I think it's a good sign that multimodal discussions with the patient and the department, rather the other way. Department first.
Abhay, we also follow it in KEM. You can't forget KEM so fast.
I did not say that. I did not say that. You and me did it. Not other people did that.
Yeah. So anyway, so we, of course, that's the most important thing, that we have a
communication is something which is extremely important. First within the departments and the patient and the counseling that has to be done. Shilpa does it very well at KEM Hospital. I have to really salute her for that. And I used to do it when I was in KEM. I don't go to beyond that, but that is the approach when there is a double malignancy that has to be treated. Thank you.
I think what Abhay said, communication, I think, is the biggest key here, because we know the patient's not going to, is not going to do as easy as just one malignancy. So you have to talk him and walk him through the entire journey of what's going to happen to him and what all he'll have. And I think once you do that, patients tend to be far more compliant to the treatment. So yeah, that multidisciplinary team has to happen. That there is no second way about it. But yes,
this patient is a chronic smoker also. Almost 30 years he is smoking, and there would have been also one of the predisposing for both the lesions to come separately.
Yes, there's so many factors that can.
Is the meeting off record or it's on record?
What is on record?
No, meeting, Kanagwell.
Sir, it is on record.
Then I'm not going to speak and respond to Jailal.
Okay, so there are multiple risk factors. All of them could. The patient doesn't give any history of change in voice, does he?
He gave change.
Yes,
so there is history of change.
He came to the OPD only with a change of voice and the swelling in the neck. And
so
what happened at the breast was a
which part of the voice box, or which part of that area is most likely to present with a unknown primary? Which is the area which is most commonly affected in an unknown primary?
But in fact, it has not. I mean, we did an endoscopy also. Endoscopy has proved there is a growth in the epiglottic region.
Okay.
Just close to it. There is a lesion.
Epiglottis, huh?
Epiglottis region.
Okay. All right. Strange again.
And but the CT report says there is a parapharyngeal, tonsillar fossa. There is a growth.
It's more likely to be in the retromolar and that area. Again, one MRI probably. I mean, it's a difficult case. Yeah. So I think from my side, I've done. Malti, if you have any more questions or doubts, otherwise I'll sign off.
Madam, we'll quickly listen to Khanna sir. Khanna sir is waiting to give his comments.
Okay, sorry. Go ahead.
Right. I think, as a rule, you have to explain everything by one pathology. But probably this is not true in this patient, because the biopsy which has come out from the notes is a squamous cell carcinoma. and from the breast, it is the adenocarcinoma. So definitely we are dealing with the two pathologies here, and two separate cancers are there, synchronous cancers which are there, occurring at the different places here. So I think probably in this patient, if you overall look at the primary, which is there in the aryepiglottic fold, which is there with the big lymph nodes which are there in the neck, and also there's a big primary in the breast also. It's almost a 6 centimeter size primary in a male breast. So it is quite an advanced one which is there in the male breast if it is there. So this patient, you should give some type of the neoadjuvant chemotherapy, which has got effect both on the squamous cell carcinoma as well as the adenocarcinoma there. So if you can have a combination of some type of that therapy, like we can use the carboplatin for that, or you can use the paclitaxel for that, where it will be effective probably on both the type of the carcinoma, adeno as well as the squamous cell carcinoma, and then see the response at what is happening to that. And probably this patient may not require any surgery, but followed by that, the patient may require the concurrent radiotherapy for that, both for the breast as well as for the neck also. So that will be probably in my patient, depending upon that, what is the response there, we will assess that. Yeah.
I think
Would you like to
I
add
should be agreeing with Dr. Khanna, because we don't know which to treat first. That is the issue. And that's why I think surgical ablation in any of these two modalities is going to confuse the surgeon. So I think I agree with Dr. Ajay Khanna.
Yeah, so probably, I don't know. The only problem is if it's a triple negative, it responds much better to platins in terms of an IDC. I think taxanes, that's what. So in NACT, taxanes probably would have to be given in this case, watch for response. And then my take would be still, once that's done, if the breast is amenable, operate the breast and then chemoradiate the epiglottis. What is the biopsy on the epiglottis?
Biopsy was taken from the lesion which is posterior to the tonsillar fossa. It came as squamous cell carcinoma.
So that is also squamous, and the cervical node is also squamous, right?
Yes, ma'am.
So that will respond well to chemoradiation. And I still feel if the breast is local, then after taxanes and maybe, I don't know, mix it with platins, operate the breast and then chemoradiate the rest. That's how I would probably take it. But I guess each of us has our own methodology to thinking about what, and I'm sure they're all correct in their own manner. Do what is comfortable and talk to the team and do it. That's about it.
I think we'll wait for the Kanyakumari team to manage and get the feedback based on the outcome.
Yeah, please do.
I think the candidate has done very well. She was in a quandary what to do. So let us give applause for her.
Thank you, sir.
As far as treatment is concerned, each one has their different ways of doing things. The patient has to be palliated first for the first complaint. Let us palliate that. Thank you.
Ibrahim sir, I could see your hand going up, sir. Ibrahim sir?
Yes, sir. So I just wanted to share.
Yes.
Yes, sir. Yes, sir. Just I wanted to share my own personal experience of double malignancies in breast. So
Yes,
I have seen cases of double malignancy. So with involving breast alone. So most of the time, 3 cases it was with breast and thyroid, one with breast and stomach, and breast and soft tissue sarcomas. So all the time, fortunately, everything were surgically operated initially and treated with the chemotherapy, which is a combination which will take care of both. So most of the time. And this is the first time I'm seeing a male CA breast with a double malignancy. Male CA breast also I have operated nearly 8 to 10 cases. So in an exam point of view, Maladi should make this point, even though she has done very well. So most important thing is the surgery has to be done early in a male CA breast. There should not be a delay because it spreads very fast. And as Shilpa ma'am told, most of the time we have to remove the pectoralis major also. The most important complication in male breast carcinomas is
The closure will be
So you are
Sir, you're
muted.
muted, sir.
Unmute yourself. Unmute. Yeah.
so most of the RT also. So the split skin graft is of not use. So we need to have a flap. So the most commonest flap I have used in such inoperable disease or a locally advanced disease is an LD flap, latissimus dorsi flap. So that is very, very useful, and that has to be kept in mind. And in almost 100% of the cases, male CA breast RT is needed. RT is mandatory. And most of the time, and I have seen, except for one case, all the cases are ER positive. Only one case I got it as a negative case. All are ER positive, and they will have a hormonal treatment. And most of the time, this hormones and chemotherapy should not be given. I have seen sometimes chemotherapy, chemoradiation going on for some other pathology, and at the same time, they will take this tamoxifen also. The problem is tamoxifen is a static. It makes the cell static, cytostatic. But chemotherapy is cytocidal. So a cytocidal drug will not act when the cell is static. So whenever you are giving chemotherapy, the tamoxifen should be stopped. So these are some of the points which have to be kept in mind. Otherwise, it's a very good case. And I think GKMC Kanyakumari team will update us in the coming weeks about how the disease was managed. Wonderful presentation, sir.
Is there any place for doing a bilateral orchidectomy in a CML breast nowadays?
No.
I have not come
Because that
across.
used to be treatment in the past, yeah.
Yes. Now it is not done, sir. It is not done.
Okay.
Not any. Anyway, it will be an external source of estrogen if at all it is available in the male. So that's why I was telling Abhay you should do an adrenal also. So there will be an external source if at all. And I think tamoxifen works for that reasonably well. You can give tamoxifen with Herceptin, but targeted and immuno. It is only, you have to remember not to give it with chemotherapy. And that's a very important point that Dr. Abraham made. You cannot start the two together. You're just kind of killing one with the other. But with Herceptin and with everything else, you can give hormonal therapy. Yeah, because Herceptin goes on for a year, so you can't stop there. Yeah, but Malti, well done. And you will never ever get a case like this in an exam unless the examiner is really, really a bad person. But other than that, it will be one of the two. And you've kept your head, and you've taken the hints and the leads, and you've done well. So good show.
Thank you.
Thank you, ma'am. Thank you, faculty.
I hope you get this case in the exam. You will always pass.
Can I hear, sir? You are missing. So thank you very much, faculties, for joining and for this.
Yeah, Jailal, I'm always there.
Yeah.
You are my good friend.
Sir, nice to see you, sir, because last time you came.
I'm in my home dress, so I don't want to come on.
Okay, sir. Please do come, and this will be
Yeah,
always you.
I'm always with you, and you're a good friend of mine. Even Ajay is a good friend of mine. So any academic activity, anytime, though I have retired, I will join as a spectator or a intrudent. Only two ways.
Thank you.
It will be always our pleasure, sir.
I have a highest respect for you.
Thank you, sir. Thank you very much. We'll call it a day. Thank you for the participation.
Thank you.
Thank you, Manavi, and all of you. Thank you.